Really, we ought to be talking about the dementias in plural because there's probably 30 of them all together. And I'll give you some examples of these. First of all, let's talk about some definitions. There are some normal definitions.
Did we have some handouts you said?
On the table over here.
Oh, believe? Okay.
Yeah, pick one up if it looks like it might be useful. Of course, at every age, there's a range of normal for cognitive testing to see what cognitive abilities you have, and that does vary somewhat over an age spectrum. The problem with that is that there's been more and more question about how valid are the earlier studies that we're relying on what a normal person's intellect ought to be at, say, the age of 80, 85, and so forth. People are living longer and living healthier for longer, so the old norms probably just aren't as reliable as they used to be. That's one problem. Then as you begin to drop from the normal population into a lower cognitive performance, you enter what's called minimal cognitive impairment, or MCI. You'll see that in the newspapers and in the medical literature a lot. And basically, this refers to what the way to think of it is benign forgetfulness. People are having some difficulty with memory, but it's not enough to interfere with their daily function. They can still eventually remember where they put the car keys, for example. Things like that. It has not caused them to be unable to do their usual activities and take care of their own business and things like that. And it does not necessarily mean that you're going to go into progressive dementia, but it does identify a group of people that are much higher risk. And finally, as things progress even more in cognitive testing, you develop a true dementia. And that suggests that there's a memory problem, but it's more than just simple memory. We just kind of lump everything together as loss of memory, but it really is other areas of cognitive realms that you have trouble with too. Judgment being one. Another is executive functions, which means that you have the ability to do a certain thing, a small task, but putting it together as a part of a bigger thing is impossible. Executive functions, a common everyday thing that people begin to have trouble with in dementia is simply getting dressed. When I get the history that a person's dressing in a bizarre way, initially it may be something subtle like just putting on a shirt and pants that really don't fit together. And someone who's been pretty fastidious with that sort of thing in the past might be an example of a problem with executive function. But later on, as it gets more obvious, people may forget to put on their underwear or put it on after they put on their outer clothes. So you'll see a lady with the blouse on with the bra on the outside. Or they may put their clothes on backwards so that the back is in the front and vice versa. Those are kind of executive functions.
Could you also say an executive function would be like wearing dirty clothes all the time instead of clean clothes?
Yes, that would be, that's more of sort of an example of it, but that also fits under the thing where people, as they get demented, may become less aware of just cleanliness in general, have trouble remembering or not wanting to take baths and that sort of thing. All those are the symptoms of dementia. It's not specific to any one kind of dementia. There's some behavioral issues with emotional ability in some dementias. People will be going along just fine and kind of lose their temper erratically and without any real reason to. All those things can be part of the dementia. They're not simply a pure memory problem. And that comes out in even the little simple testing that we do in our office. Well, what are some common examples of dementia? The most common trio would be Alzheimer's disease, as described by Dr. Alzheimer in the 1870s. And that diagnosis is really ultimately dependent on brain pathology, which shows that there's a buildup of an abnormal protein called amyloid protein. And you see under the microscope typical tangles of neuronal processes and plaques that are glumps of this amyloid. Amyloid accumulates inside neuronal cells and kills them, so it's neurotoxic. The next most common dementia would be vascular dementia, which is related to small vessel blood flow problems. Evidence for that we see on MRI scans and sometimes on a CAT scan if it's really badly, where there's some changes around some structures in the brain, some hollow places in the brain called the ventricles. And following the contour of the ventricles, you see these white matter hyperintensities. That's what we neurologists refer to them as. The radiologists refer to them as microvascular disease. That's kind of a fuzzy point. But they're typical images that would go along with vascular dementia. Now, pure Alzheimer's disease and pure vascular dementia is actually not that common. They're little subsets of the bigger picture, which would be a mixed dementia. And you have signs and symptoms and pathological characteristics of both illnesses in the same patient. And that's what we see most of the time. And that'll explain why some things I'll recommend later on seem to help. There are other common degenerative dementias. The most common of those you're hearing about a lot in the lay press, called frontotemporal dementia or frontotemporal degeneration. Refers to those frontal and temporal lobes that seem to be selectively affected by this problem early on. The old term for that was Pick's disease. It tends to start occurring in younger ages, and people begin to do relatively bizarre things and have strange reactions to situations early on in the illness. For example, I had a man in his late 40s who was an executive downtown for an oil company, and his wife's first inkling that there was something wrong, this guy who was a fitness enthusiast, he liked to run a lot, couldn't find his car one evening in the garage, so he walked home. He lived in the Woodlands, and he walked from downtown to the Woodlands that night. That was her first sign that something was wrong. But he wound up having Pick's disease, and it was just an example of another type of degenerative dementia. There's a dementia related to Parkinson's disease. About 30% of patients with Parkinson's have a dementia related to the Parkinson's. There's also, as a group, or tend to be elderly, and they have the same risk of having Alzheimer's disease and vascular dementia as the other people in their age group. So sometimes it's hard to separate what's from the Parkinson's and what's from other kinds of dementia. There's some nutritional dementias. The most common of those is B12 deficiency. B12 deficiencies cause all kinds of neurological syndromes, beginning from the peripheral nerves to the spinal cord and then to the brain. And some people have all of it together, which is referred to as subacute combined degeneration. But that's a treatable dementia. You can treat that and stop the dementia, sometimes make it get dramatically better. The next most common nutritional dementia would be alcohol abuse. And that changes, not only is it directly toxic to brain, but it also changes your absorption of other B vitamins like thiamine and folate. And they in turn then can cause problems with brain function. You can have dementias related to other medical problems. Best example probably would be thyroid disease. People who have either high levels or low levels of thyroid can have cognitive problems related to it and classify as a dementing illness. People who have diabetes have a much higher incidence of dementia, probably because of the effect of the diabetes in small blood vessels. Another one is hypertension. Hypertension can cause a thing called Binswanger's disease, and you have these typical white matter, horrible degenerative problems in the frontal lobes that have been identified for decades as Binswanger's. It probably is, again, an example of small vessel vascular changes, but it's brought on by high blood pressure. And one more reason why internists are always banging on people about taking care of their blood pressure and their diabetes. You put diabetes and blood pressure together in the same patient, and you just magnify the adverse effects of all this stuff. And there's some infections, infectious diseases that cause dementia. Historically, before the introduction of antibiotics like penicillin, the statement was that you could teach all of medicine based on syphilis. It could cause such a variety of problems in the body that you could teach virtually every medical specialty off a syphilis case. And one of those things was dementia related to general paresis of the insane is what it was called. But it was a degenerative change in brain brought on by the spirochete. Everybody's heard of AIDS and HIV infections. From a neurological point of view, this is a horrible illness that causes terrible dementia in younger people. You don't have to wait very long to get it. Fortunately, nowadays with the retroviral agents, you can treat it. We don't hear about it much right now anymore, but there's a group of illnesses called the prion diseases. The most published, the most widespread of those that everybody was hearing about was mad cow disease. It could cross species boundaries, and people in England got the prion, the infectious particle, from beef contaminated with mad cow disease. And they developed in younger people a particular dementing illness that was preceded by severe depression that came on abruptly. When you look at the brains in people with prion transmitted diseases, they have what's called a spongiform encephalopathy. Encephalopathy just means that there are changes in the brain tissues. Spongiform means that it looked like a sponge. They're just big holes just punched out of the brain when you look at it under the microscope. Historically, the most important of those was, of these prion diseases, was a thing called Jakob-Creutzfeldt disease. And it occurs about 1 in a million patients yearly. So there's this underlying very low level incidence of Jakob that is in virtually every Caucasian population in America and Europe primarily. And I've had 4 cases over my career, so it doesn't happen frequently, but it's very characteristic. It's a horrible, horrible illness. Every now and then some legislator thinks that we're not doing enough to monitor this, and there'll be an outbreak somewhere, they think. And the health department then goes around and does surveys. There's never been a real outbreak. What happens is that someone just identifies a couple of cases in a given area, and it seems to get everybody's attention. But in fact, it's very steady, very consistent, about 1 case in a million people every year. So it's out there, not very often. The prions they're not a bacteria, they're not a virus, they're an infectious protein. And it takes over the genetic machinery of the cell and reproduces itself and eventually kills the cell. That's the difference between prions and viruses. But it's a protein. It's very hard to wipe out and kill. If it gets equipment or things get contaminated, it's almost impossible to get rid of it without just burning the stuff. It was not sterilized by usual autoclave methods or chemicals that were used to sterilize instruments. As a result, there was a rash of cases passed on with retinal transplants, where you're transplanting biological material. If you happen to get some material from a patient infected with the prion, then all their tissues are loaded with it, and so the recipients of the retinas or whatever would develop the Jakob-Creutzfeldt. Had one neurosurgeon who developed Jakob while he was doing a brain biopsy on a patient. A fellow by the name of Gadjicek won a Nobel Prize because he worked out that this was an infectious disease. It was not Jakob-Creutzfeldt, but a variant of it. It's a little bit different, that were in headhunters in New Guinea. And they found that the women in this society didn't get the problem, but the men didn't get the problem because they would, when they killed an enemy, they would cannibalize his heart. They'd eat his heart. They didn't seem to have a problem, but the women would crack open skulls and eat brain, and they got this ataxia falling disease that was passed by a prion. Gadjicek was a real jerk in the sense that he brought young boys back from the Philippines. He's now in a federal penitentiary for all kinds of deviancy that he did on these kids. So he was a brilliant man, but weird. How do we work these things up? There's a battery of tests. The first thing to do is a simple neurological examination to make sure there's not something else going on. The first thing I get is an MRI of the brain. Personally, I don't think that a plain CT scan tells you as much as you need to know when you're working up a person with possible dementia. We talked about the medical problems like hypothyroidism and things like that can cause dementia, so I get a blood chemistry battery. There's some psychological testing that is aimed at cognitive function. There are psychologists in the medical center that do nothing but cognitive testing. And that's been, until now really, the most accurate, best way to confirm the dementia. And it also gives you an idea of where they are as far as being able to live alone and to drive and to do those sorts of things. The driving issue has gotten to be an increasingly big problem for the dementia, just because our population is aging. We're seeing more of the dementias. It's not more common per capita, it's just that there's more of us to get it. But the driving issues are complex. We don't want to take the driver's license away from people who may be mildly demented but can still function and drive and not get lost and not be a threat on the road. But at some point in time, almost all those patients are going to develop a problem with it, and you have to take the car keys away. That's very difficult to do. I recently helped, it was about 6 months ago, I helped rewrite the rules that the Medical Advisory Board in Austin uses to make driving assessments on patients with dementia. Interesting enough, if you want to look at one single thing that gives you a good predictor of who's going to be at risk for driving problems, is what the family thinks of the driving. Rarely does the patient have enough insight to tell you. But when people in the family say, well, we're not going to ride with Pop anymore because he's just not safe to ride with. Or, geez, my mom is very careful, but she only drives about 20 or 30 miles a week just to go to the grocery store, just to go to church. That's a big red flag. And besides that, they say she'll only drive in good weather. Doesn't drive in the rain or at night, another red flag. and she tends to get lost. This is the thing that worries me the most. People tend to drive off in their car and can't find the way back. And I'll tell you a personal story that illustrates it. My mother-in-law was beginning to have problems, and we tried to get her to stop driving, but she lived in Texarkana, or in a little suburb of Texarkana, and we were in Houston, so she could safely tell us to go stick it, you know where, which is what she did. From her front porch, you could see her grocery store that she traded at. From the grocery store, you could see her house. Well, one day, she went to the grocery store, and we know that because we found the sales slips and the food. But when she got in the car to go home, she got turned around, wound up on Highway 59, and went to Joplin, Missouri. And she recognized the name Joplin, called her sister who came and got her, and they called me, and I flew up and drove her home. That's what I worry about. I've had people who wandered off, got lost in their car, got stuck out in the country. One couple got in a deep ditch with tall grass on either side. They almost died of dehydration out in West Texas when they came from Angleton. They meant to go to the grocery store too. Maybe something with the grocery store. That's the issue with the driving and getting lost. The new diagnostic tool that we're able to offer here, and as far as I know, is only available, the next place you could go to get it would be in the medical center, is a SPECT scan, and that shows a very characteristic uptake of dye in the radioactive tracer, I should say. It's a nuclear medicine imaging technique. In normal areas versus abnormal areas, and with a second phase with a drug called Diamox, we can separate out Alzheimer's changes from vascular disease. And that makes a big difference in treatment because we can do a lot more about the vascular causes of dementia than we can typical Alzheimer's. And remember that most of the patients are going to have a mixture. And so we're in the phase, this is a new thing, new machine, a new software that we've just gotten here, and we're still doing a few volunteers to get a good feel for the procedure before we start doing it widespread. But we do have this available nowadays here. Now, as far as treatments, and this is where the brain health comes in, there's a couple of drugs that help, the so-called anticholinesterase inhibitors, which are donepezil, trade name is Aricept, and rivastigmine, which is trade name is Exelon. These slow down the breakdown of acetylcholine, which is the neurotransmitter in the cortex of the brain, the outer layer of the brain, that's been associated with the dementias. It's not the cause of it, it's just the result of the degenerative process that causes the memory and cognitive problems. So if you block the breakdown enzyme, you keep the titer of acetylcholine higher, and people think better. Now, you have to understand what to expect with these drugs. They don't necessarily make people's cognitive function improve. The idea is they keep it steady and keep it stable. And by doing a mini mental status test, we can trace that over time, compare the pre-treatment with post-treatment phases, and you find that it doesn't deteriorate as fast as patients who are not being treated at all. So there's definite benefit. You can show a very definite benefit from it. It's just it's not a very dramatic improvement, which is disappointing to everyone, me included, but that's what we've got to deal with. That's what we have available to us. There's another drug called memantine. I'm less enthusiastic about it. It's never been as effective as the others, and recently it's been, up until recently, we've all been using the two together. We add one of the anticholinesterase inhibitors and then later on add the memantine to it. But there's a relatively large study that's come out recently shows there's no advantage in combining the two together. So I'm probably going to go back to just using one of the anticholinesterase inhibitors alone. and they both work pretty well. The next thing that you look for it to do would be to eliminate things that may make the problems worse, especially sedative drugs, anything that causes sedation. The biggest offender probably is over-the-counter antihistamines, or the PM products, which the PM in there is Benadryl. It's an antihistamine. It's very sedating, and it just makes the dementia just worse. It's just a pure problem associated with the sedation. Sleeping pills, any drugs that have sleepiness as a side effect are going to make the cognitive problems worse. If you use those medicines, or if those medicines are being used, a short-acting drug is going to be better than a long-acting drug, because the long-acting drugs tend to build up and have, progressive worsening of the problems. Then, based on the evidence that's available, there's the things that I recommend to help either prevent the progression of the memory problems, or maybe even, or at least it slows them down, but it may actually prevent going from low normal function to minimal cognitive impairment and then on to dementia. The first of those we've already implied is treat whatever underlying medical problems are there and get serious about it. People are kind of blasé about their blood pressure. We need to get them to take good care of it. Same with diabetes. If you get those under good control, that's a big step. So treat the underlying medical problems. The next is exercise, cardiovascular exercise. If you go to meetings and I see these cognitive neurologists that do the research in the areas of the dementias, they'll get into sometimes almost physical conflicts on the stage, and people get real intense about it. Everybody agrees that cardiovascular exercise, for some reason or another, helps you think. It helps your memory. It helps your cognitive function. Nobody knows why. There's all kinds of good theories. None of them have been proven, and these people get very passionate about it. But right now, there's no good answer about why it works. We just know that it does. If exercise for your body and your heart especially works, then exercising brain works. That's what I refer to it as. And by that I mean things that stimulate you to think. And probably the easiest, the best is just social interactions. A group like this where everybody's talking together and you're conversing back and forth, exchanging ideas and just visiting is very stimulating to brain to keep synapses that are already there and to build new ones. So people who get demented oftentimes get isolated. They end up in the back bedroom watching TV all day and they get worse faster. That's why going to an adult living, patient day out sort of thing may cause patients to actually bloom a little bit and get better, because that social stimulation interaction is very important. So it's 2, 3. The other one is diet, and there's actually some good evidence about what kind of diets work to help dementia. Generally speaking, it's a low-fat, heart-healthy sort of diet. The one that's been actually studied and has the best evidence with several tens of thousands of patients has been the so-called Mediterranean diet. It's the kind of foods are eaten around the boundaries of the Mediterranean Sea. And it's basically low-fat meats, chicken, lots of fish, vegetable sauces, fresh vegetables, fresh fruit. Not a lot of fatty foods. The nice thing, the reason I like it so much is I took it last summer with my wife. We took a trip to Italy. And you know what? Those Mediterranean diets are really very palatable. I could live on that stuff forever, as opposed to some of the other really restrictive diets that you see recommended. You can't